Thank you, Chairman, for your kind introduction. Today, I'll be presenting a study examining the relationship between donor warm ischemic time and the biliary stricture outcomes in pure laparoscopic donor right hemi hepatectomy. I have nothing to declare. So pure laparoscopic donor right hepatectomy, or PLDRH, has gained widespread adoption due to its minimally invasive nature, benefits, and established donor safety profile. Now, our center has made the transition ages ago, and today we perform virtually all donor cases using laparoscopes. In 2022, our center published these findings suggesting that laparoscopic donor surgery might impact the recipient biliary complications, particularly the biliary strictures. This analysis covered patients from 2010 to 2018, and reflecting on these results, two key questions emerged. First, could these outcomes be related to something called the donor warm ischemic time? And second, since this report reflected our earliest laparoscopic experience and experience of multiple donor surgeons, would we see different results now that we have overcome this learning curve? Let me define donor warm ischemic time. This represents the interval from when the graft liver is cut off from its blood supply and until it's extracted from the donor and placed in the cold perfusion solution. Now, we defined it especially as the time from hepatic artery ligation, as we thought this better accounts for the bile duct perfusion. In PLDRH, this is what the donor warm ischemic time would look like in the video. And donor warm ischemic time is typically longer in laparoscopic surgery than in conventional open surgery because some extra time will be needed to change the instruments and some time will be needed to open the peritoneum and get the graft out like this. And this is not the same as the Pringles maneuver because there will be no immediate reperfusion. The graft still faces the cold and warm ischemic times after this. And with this background, our study had two primary objectives. First was to investigate whether donor warm ischemic time contributes to biliary recipient's biliary stricture formation. And second, to re-evaluate the biliary stricture outcomes from laparoscopic donors using updated data and experience, and also by addressing the limitations of a previous study by analyzing data from a single donor surgeon. And this is a retrospective single-center study. We included living donor liver transplantations performed between January 2011 to November 2023 by a single donor surgeon. Our inclusion criteria were ABO-compatible donor-recipient pairs who used the right hemi liver graft, biliary reconstruction, which was done duct to duct, and recipients with at least 1 year of postoperative follow-up. We categorized the patients into 3 groups based on the donor's surgical approach and time period. Group O was for open donor hepatectomy, which was 2011 to 2015. Group EL for early laparoscopes, 2016 to 2018. And Group LL for late laparoscopes, 2019 to 2023. We also collected the following data. Donor warm ischemic time was defined as the interval from hepatic artery ligation to graft extraction. Biliary strictures requiring interventions above Clavien-Dinder grade 2 were analyzed as our primary outcome. We also analyzed potential risk factors for biliary strictures in laparoscopic donors, in recipients. Our study included 264 donor-recipient pairs, 103 in Group O, 49 in Group EL, and 112 in Group LL. The patient demographics varied slightly across the groups and across the years. An interesting thing was average donor warm ischemic time differed significantly between open and laparoscopic groups, which was 5.9 minutes in the open group, 11.4 minutes in the early laparoscopic group, and 10.7 minutes in the late laparoscopic group. Well, there was no significant difference between the group EL and LL, but we did see some improvement of time with experience. This is a Kaplan-Meier curve, which shows biliary stricture-free survival in the recipients. And unlike our previous report, the overall incidence and stricture-free survival showed no significant difference between the groups. This graph demonstrates the relationship between donor warm ischemic time and biliary stricture incidence. We observed an increasing trend in biliary stricture rate as donor warm ischemic time increased after a certain point of time. And using an ROC analysis, we identified a cutoff of about 12.5 minutes that predicted increased biliary stricture risk with high specificity and statistical significance. And this 12.5 minutes threshold correlated quite well with our incidence graph. And since our hospital records measured the time in only whole minutes, we established our threshold at 13 minutes. The univariate analysis identified 3 significant risk factors for biliary stricture in recipients: preoperative external radiotherapy for HCC cases, prolonged donor warm ischemic time, which exceeded 13 minutes, and recipient hepatic artery complications. And the very same 3 factors occurred in multivariate analysis. So they were identified as independent risk factors for recipient biliary stricture, validating their clinical significance. And finally, we conducted a separate analysis to identify factors that might cause the donor warm ischemic time to exceed the 13-minute threshold in laparoscopic settings. Multivariate analysis revealed that having more than one right hepatic artery, anatomic variations in the right portal vein, and as well as the presence of a significant right inferior hepatic vein were the risk factors. And logically thinking, these things require extra time and attention when dividing them in order to prevent donor complications and to ensure a smooth anastomosis on the recipient side. So in conclusion, this study demonstrates that the complication-free survival for biliary stricture in recipients was comparable between open and laparoscopic donor hepatectomy, suggesting that the donor's surgical approach itself may not be a significant impact factor on recipient biliary stricture-free survival. However, a prolonged donor warm ischemic time exceeding the 13-minute threshold emerged as a significant risk factor, with consistently longer durations observed in PLDRH. And these findings emphasize the need to try to minimize the donor warm ischemic time, particularly in laparoscopic settings, to optimize the biliary outcomes in the recipients. And thank you for your attention.